Welcome to the deep dive. Today we are undertaking an analysis of what is arguably the single most damaging structural crisis facing the United States economy and its public health system, the drug crisis, fueled primarily by illicit opioids.
It's a staggering issue. And when you start tracking the costs, you realize this isn't just a social problem. It's really an existential one. The economic impact alone is unbelievable.
I saw the numbers in our source material. What was the estimate for 2023?
Our sources estimate that illicit opioids cost the U.S. economy about $2.7 trillion.
$2.7 trillion. That figure is almost impossible to grasp, but to put it in context for you, that's equivalent to 9.7% of the entire U.S. GDP. It's like the cost of a war fought entirely on domestic soil.
And when you break down that number, that's where you see the true human catastrophe. The largest costs are not law enforcement or even healthcare.
Yeah.
About $1.34 trillion, so nearly half of the total is attributed directly to the lost quality of life for those struggling with substance use disorder. And another $1.1 trillion is the cost associated with premature deaths.
But we aren't undertaking this deep dive just to catalog the tragedy. We're here because our sources are pointing to a major and very encouraging turning point.
Right. There's actually some good news. Provisional figures from 2024 suggest the U.S. has seen an estimated 27% decline in overdose deaths.
A 27% decline. A drop of that magnitude it's historic.
It is. It means that something fundamental in the policy and public health approach has finally started to shift.
Absolutely. So our mission today is to dig into the foundational research. We're looking at reports from the DEA, the CDC, and various public health analyses to understand two things for you. First, what are the deep, fundamental structural causes of this crisis, moving far beyond the media stereotypes?
And second, and this is the crucial part, what are the fundamental solutions that are actually driving this recent progress?
We need to understand not just the drugs, but the system collapse that allowed them to flourish, and it's a scientific paradigm shift that is finally offering a way out.
Okay, so let's start with the history.
Right. Let's unpack that first. We often talk about the crisis as this monolithic thing, but our sources clearly delineate its structure into three distinct waves. And the journey begins, surprisingly, in the doctor's office.
That's exactly right. The first wave, spanning roughly 1999 to 2010, is known as the iatrogenic epidemic.
Iatrogenic, meaning?
Meaning illness caused by medical intervention. This was the era where pharmaceutical companies, like Purdue Pharma, were aggressively and misleadingly marketing opioid painkillers.
We were the ones who pushed that idea of pain as the fifth vital sign, right?
Exactly. They convinced doctors and hospitals that it required aggressive treatment, all while downplaying or just flat out lying about the profound risk of addiction.
And the result was a huge explosion of access.
A massive one. Consider this critical stat from that early period. 75% of patients who started misusing opioids first got them from a physician's legitimate prescription.
75%. So the medical system itself was the massive, if unintended, gateway for the whole crisis.
It was.
So if the legal prescription system was the problem, how did we shift to the street drugs we associate with the crisis today?
Well, that takes us to wave two, which is roughly 2010 to 2013. This is when regulatory bodies finally reacted.
So they started to tighten the screws.
They did. Doctors were compelled to track patient histories using PDMP's prescription drug monitoring programs, and manufacturers introduced those tamper-proof pills. The supply of cheap, legal opioids tightened dramatically.
Which created a kind of prohibition paradox, didn't it?
Yeah.
When you cut off the legal supply for people who are already dependent, what happens?
You get what's called the balloon effect. You compress the legal supply, and the demand immediately bulges out into the illegal, unregulated market.
So users migrated.
They did. People who were already dependent suddenly faced higher prices, less availability for pills, and they moved very quickly to cheaper, more available illegal heroin.
And the data shows this direct, tragic migration. I remember reading that somewhere between 4 and 6% of prescription opioid misusers transitioned directly to injecting heroin within 5 years.
That's the figure. That migration is what set the stage for the next, and by far the most deadly, chapter.
Which is wave 3, the fentanyl supply shock, from about 2013 to today.
Right. And now heroin is largely obsolete. It's been replaced by illicitly manufactured fentanyl, or IMF, fentanyl just. It completely changed the chemistry of the crisis.
It's a logistical nightmare for law enforcement and, frankly, a clinical death sentence for users. It's cheap to produce. It's 50 times stronger than heroin.
And it's incredibly easy to smuggle because you need such tiny volumes for a massive effect.
But the primary danger today isn't just people knowingly using fentanyl, is it? It's deception.
It's absolutely deception. The DEA's recent assessment confirms the biggest threat is counterfeit pills. Cartels press IMF into pills that look exactly like prescription drugs, like those familiar blue M30 oxycodone copies.
So the user has no idea. They think they're taking a safe or at least a familiar painkiller.
Precisely. And the lethality is staggering. Reports show that 7 out of every 10 seized counterfeit pills contained a lethal dose of fentanyl,
7 out of 10.
which leads to accidental death among users who have no history of synthetic opioid use. And that is why fentanyl is now implicated in about 69% of all overdose deaths as of 2023. It's the dominant killer, but it was invited into the market by the systemic failures of the first two waves.
That structural history is so important, but to really get to the bottom of this, we have to stop focusing only on the product, the drug, and start asking, who is the patient? Why are some people vulnerable in the first place?
Right.
For years, drug policy was based on this really simple and, as it turns out, flawed gateway hypothesis.
Precisely. The gateway hypothesis suggested this linear path. You use a soft drug, like marijuana, and that biologically predisposes you to graduate to harder drugs. It was the foundation for the punitive war on drugs framework for decades.
But researchers did find correlations, didn't they? That the sequence of drug use, alcohol, then marijuana, then something else, was pretty consistent.
Correlation is the critical word there. Modern science has looked deep into the brain chemistry and epidemiology and found the gateway theory just confused correlation with causation.
So it's not a biological necessity.
No. The sequence of drugs someone uses is often determined by social context and easy access. You can buy alcohol before you can buy heroin. It's about opportunity, not brain chemistry forcing you up a ladder.
So if the gateway hypothesis failed, what's the modern scientific standard for explaining addiction and vulnerability?
We now rely on what's called the common liability model, or CLA, and this model shifts the focus entirely. It argues that addiction isn't about the specific drug you start with. It's driven by shared underlying factors that create a general susceptibility to any substance use disorder.
Okay, so help me understand the components of that underlying vulnerability. What are those factors?
They fall into two main buckets. First, you have biogenetic factors, things like inherent differences in your brain's dopamine reward pathways that might make you more sensitive to addictive feedback loops.
And the second?
The second, and maybe more important for policy, are the psychosocial factors. This includes high rates of what we call adverse childhood experiences, or ACEs, poverty, economic instability, and trauma.
That makes perfect sense. This model immediately connects the dots between the addiction crisis and the parallel mental health crisis we're seeing. They share the same roots.
Absolutely. The common liability model accounts for the massive comorbidity we see. For example, nearly 10% of young adults aged 18 to 25 experienced a serious mental illness in 2020. This despair. It's the fertile soil where addiction grows.
This brings us to what I think is the key aha moment statistic from the source material. It just fundamentally changes how you think about drug initiation. If we're talking about prescription opioid misuse, the initial seed of the crisis, where do users actually get those drugs?
This is a fact that should rewrite every drug prevention campaign. You might assume people are getting them from a street dealer, but the data from the DEA and the National Survey on Drug Use and Health is just stunning.
So what percentage of initial misusers get them from a drug dealer or a stranger?
A tiny fraction, 7.6%.
Just 7.6%. So who is the overwhelming source of these addictive pills?
A massive 86% of initial misusers get them from sources that are either structural or interpersonal.
Okay, break that down for me.
We're talking 42.3% from friends or relatives, often just taken from a medicine cabinet without permission, and 43.7% receiving them directly via a legitimate prescription from a healthcare provider.
Wow. That statistic right there fundamentally proves why the supply-side war on drugs, focused purely on cartels and street crime, is just. It's fundamentally insufficient.
Exactly.
It means the initial source of the epidemic isn't some shadowy figure in an alley. It's the unsecured bottle of leftover pills in suburban America and the doctor who overprescribed them.
It demands that we seal the entry points in the home and the clinic first, before we focus solely on international interdiction.
Okay, so let's quickly look at the current reality on the streets. We've talked about the 3 waves, but the present danger is often called the 4th wave.
Polysubstance use.
Right. Fentanyl is now being combined with everything, and often unintentionally. We're seeing dangerous spikes in deaths involving psychostimulants like methamphetamine and cocaine.
And this isn't just people choosing to mix drugs. No, it's often the intentional contamination of the supply by traffickers to hook new users or to cut costs.
Clinically speaking, what makes that combination so lethal?
It creates what's called the masking effect. Imagine pushing the gas pedal and the brake pedal at the same time. The stimulant, like meth, elevates your heart rate and alertness, and it temporarily masks the primary danger of the opioid.
Which is that it slows your breathing down.
Right, severe respiratory depression. So the user feels fine at first, but then the stimulant wears off, and the crushing respiratory effect of the fentanyl hits them without any warning.
And if that weren't enough, there's another horrifying contaminant showing up now, xylazine.
Yes, xylazine. It's an animal tranquilizer.
Not an opioid.
Correct. A non-opioid sedative used in veterinary medicine. It's appearing more and more mixed into illicit fentanyl. And the crucial clinical nightmare here is that because it's not an opioid, its sedative effects are not fully reversible by naloxone.
So Narcan doesn't work as well.
It doesn't. And xylazine also causes these severe tissue wounds, making it much, much harder for first responders to handle these overdoses.
And we can't forget that this crisis is fundamentally driven by inequality and geography. The death rates are not uniform across the country or across demographics.
Not at all. The demographic profile is shifting. While the crisis was initially publicized through the lens of younger, rural, white populations, we are now seeing accelerating death rates among older Black men. They're being disproportionately impacted.
And why that shift to older demographics in general?
It's a convergence of factors: persistent pain management issues, profound social isolation that was exacerbated by the pandemic, and legacy use habits within the baby boomer generation colliding with today's incredibly lethal drug supply.
And geographically, the correlation between death rates and economic hardship is undeniable.
Absolutely. You see states with the highest death rates, like West Virginia, with 90.9 fatal overdoses per 100,000 people, correlating almost perfectly with post-industrial decline and economic distress. They call them deaths of despair geographies.
So the economic fragility isn't just a backdrop.
It is the soil in which this crisis is rooted. You cannot treat addiction without addressing the economic despair that drives that underlying vulnerability.
Okay, so let's pick it back to that encouraging news we started with. The 27% decline in deaths. That decline validates this massive policy shift we're witnessing, moving away from the punitive war on drugs framework toward a comprehensive public health approach.
Right. The goal is no longer a drug-free society, which is unrealistic. The goal is a society without overdose deaths.
And that success rests on three interconnected pillars. Let's start with pillar one, harm reduction. This is about saving lives right now.
And at the top of that list is naloxone, or Narcan. It's really the primary factor credited with that 2024 death rate decline.
Because it's just so much more available now.
Exactly. Its widespread distribution to first responders, to users, to family members has created a safety net that simply did not exist 5 years ago. Every life you save is a chance for that person to get into treatment.
What about other tools, like fentanyl test strips?
A perfect example of a low-cost, high-impact tool. These are simple, cheap strips that allow users to test their drugs for fentanyl contamination. Since so many deaths are unintentional, these strips directly intervene to reduce fatal overdoses. It's just a pragmatic, evidence-based tool.
And then there's the controversial element, overdose prevention centers, or OPCs.
OPCs, sometimes called supervised consumption sites, are often misunderstood. Yes, they provide a monitored environment for use, but their true public health value is that they are critical entry points.
Entry points to what?
To the system. They bring deeply isolated, high-risk users indoors and connect them directly to social workers, medical care, and treatment referrals. They aren't just facilities for safer drug use, they're a bridge to recovery services.
Which brings us to pillar two, treatment. Addressing the core demand. We have to increase access to evidence-based care.
And that means expanding the availability of medications for opioid use disorder, or MOUDO. The two main ones are methadone and buprenorphine. And these aren't just replacing one addiction with another, they're evidence-based medications that stabilize brain chemistry.
Can you explain briefly how something like buprenorphine works?
Sure. It's a partial opioid agonist. So, unlike a full opioid, it binds tightly to the opioid receptors without producing the same high. It effectively removes the craving and withdrawal symptoms.
So it allows the person's brain to stabilize.
It allows their brain chemistry to stabilize so they can actually engage in behavioral therapy and start rebuilding their life. It is the gold standard of care.
And crucially, this is where the money from those massive lawsuits against the pharmaceutical companies is finally coming into play.
Yes. The immense financial settlements, like the billions from Purdue Pharma, are being funneled to state and local governments, and that money is earmarked precisely for expanding this MOU infrastructure.
Finally, we have Pillar 3, smart policy and system fixes. We have to learn from the mistakes of the first wave.
Which brings us back to prescription drug monitoring programs, the PDMPs. Making it mandatory for doctors and pharmacists to track patient histories in real time was crucial in halting that explosion of overprescribing in the 2010s.
And on the international supply side, how do we tackle fentanyl without just triggering that balloon effect again?
Through smart interdiction, the DEA report highlights that we have to focus enforcement upstream, targeting precursor chemicals coming from places like China and large-scale manufacturing by cartels in Mexico. And we need sophisticated digital enforcement tracking crypto payments, stopping distribution via social media.
But if we cut off that supply, aren't we just back to the prohibition paradox, sending dependent users to an even more desperate black market?
That is the critical lesson learned. Any major supply enforcement has to be synchronized with an immediate corresponding surge in treatment and harm reduction resources.
So they have to happen at the same time.
Exactly. The goal isn't just to interrupt the flow of drugs, it's to ensure that when that flow is interrupted, users are transitioned directly into a functioning treatment system. Synchronization is the key.
So what does this all mean for you, the listener? Our deep dive confirms that the U.S. drug crisis isn't a simple problem of criminality. It's a complex collapse of medical oversight, economic opportunity, and social support.
And the pathway to lasting recovery requires abandoning that old punitive war on drugs framework. That 27% decline in deaths shows that embracing the science-backed common liability model and integrating these public health strategies, harm reduction, MOD, smart policy, it actually works.
And here's the final thought for you to carry forward. We began with the data point that illicit opioids cost the nation $2.7 trillion a year. That immense cost is clear data proving that investments in prevention, harm reduction, and recovery are not just compassionate feel-good policies. They are necessary, non-negotiable economic stabilizers.
Right. The ultimate solution requires us to look past the drug itself and focus on the deep social determinants of health, addressing poverty, mental health, and the desperation caused by collapsing economic structures. To achieve long-term public health and economic stability, we have to pull the root of addiction out of the ground.
Thank you for joining us on the Deep Dive. We encourage you to continue exploring the crucial interconnectedness of public health and economic stability in modern drug policy.